Hey guys, welcome to another episode of the Human AI podcast. I'm with Grog, and today we're gonna talk about diseases. And it's gonna be a cool episode because Grog is gonna create some cases, and we have to guess what the person is suffering from. So, Grog, we played this game yesterday. If you could focus on the history taking things we talked yesterday, so cardiovascular, GI, and respiratory, and make up a patient case, a clinical scenario, and I'm gonna remember, Grog. The rule is we do Socratic questioning here. Don't give away the answer. I'm going to ask you more and more questions once you give us the initial information. And hopefully, we can figure out what it might be. Then we can figure out what tests to do, and etc. So, without further ado, let's do it. Grog, mic's on you.
All right, let's jump into the game. Here's a clinical scenario. A 50-year-old woman presents with a 2-week history of intermittent chest pain, described as tight, central, 4 out of 10, lasting 5 to 10 minutes, triggered by walking uphill, relieved by rest. She also reports occasional shortness of breath during these episodes, but no palpitations or swelling. What's your initial guess for her condition, or what question do you ask first to dig deeper, keeping Socrates and history taking in mind?
So we have a 50-year-old woman that has intermittent chest pain for the last 2 weeks. It's tight and it's central, and it's a 4 out of 10 pain. It gets worse with exertion and better by rest. She also suffers from some shortness of breath sometimes, but she doesn't have any palpitations or swelling. Okay, wow. Okay, I'm gonna throw out the usual suspects we have usually, such as angina, myocardial infarction, and all of that, heart failure, etc., arrhythmias, etc., etc. And yes, let's think what it might be related to. So, this getting worse with the exertion and better with rest reminds me of angina. Although I don't know if angina has to do much with shortness of breath. I guess it does. Let's look at things. Let's go. Let's sit back. So let's see the Socrates. Let's look at things from a bit further. So the site. Where exactly is the chest pain?
Nice approach, zooming out with Socrates. The chest pain is central, substernal, right in the middle of her chest. No radiation to arms, neck, or jaw. Her 2-week intermittent pain, tight, 4 out of 10, 5 to 10 minutes, comes on when walking uphill, stops with rest, and she has occasional shortness of breath during episodes. No palpitations or swelling. What's your next question to refine your guess? Angina is a good start, or any tweak to your differential?
Well, O for Socrates, if I remember correctly, is onset, and onset I think means when it happens.
You're on the right track with Socrates. Onset in this context means when the chest pain started and its pattern. For this 50-year-old woman, the tight, central chest pain, 4 out of 10, 5 to 10 minutes, began 2 weeks ago, occurs intermittently, triggered by exertion, like walking uphill, and resolves with rest. She gets shortness of breath during some episodes. No palpitations or swelling. Want to ask about another Socrates element, e.g., character, associated symptoms, or something like past medical history to narrow down your angina guess? What's next?
Yes, that would be a good idea. Let's talk about past medical history. We also want to cover social history and drug history. Yes, past medical history. Let's do it.
Solid move digging into past medical history. You ask, and she reports. No prior heart disease, no diagnosed hypertension or diabetes, but she has high cholesterol, untreated. No history of lung or GI issues. For drugs, no regular medications, just occasional paracetamol for headaches. Social history, she smokes, 10-pack years, still active, drinks 2 to 3 glasses of wine week, works a desk job, moderate stress, no recreational drugs. Her 2-week chest pain, tight, central, 4 out of 10, exertional, relieved by rest, and occasional shortness of breath persist. What's your next question or updated guess?
Well, this high cholesterol, I wonder if it's blocking an artery.
Good catch on the high cholesterol. It raises the risk of atherosclerosis, potentially narrowing coronary arteries, which aligns with your angina suspicion for her 2-week exertional chest pain. Tight, central, 4 out of 10, relieved by rest, and shortness of breath. She's also got a 10-pack years smoking history, no hypertension or diabetes, no meds, and moderate stress. Want to ask another question? E.g., family history, symptom triggers, or lean into a test for angina? What's your move?
Let's do a test for angina.
Nice call to test for angina. For this 50-year-old woman with 2-week exertional chest pain, tight, central, 4 out of 10, relieved by rest, shortness of breath, high cholesterol, and smoking history, start with 1. ECG to look for ischemic changes, though it may be normal at rest. 2. Stress test, treadmill or pharmacological, to provoke symptoms and confirm exertional ischemia. If positive, consider a coronary angiogram to check artery blockages. Want to ask one more history question, e.g., family history before testing, or stick with this plan? What's next?
Let's do family history, but also, yes, let's stick with the plan too.
All right, sticking with the ECG and stress test plan for suspected angina and adding family history. You ask. She reports her father had a heart attack at 62. No other family history of heart or lung disease. Her 2-week chest pain, tight, central, 4 out of 10, exertional, relieved by rest, shortness of breath, high cholesterol, and 10-pack year smoking history remain key. What's your next step? Confirm the test plan, add another question, e.g., associated symptoms, or update your diagnosis guess.
Tell me again the result.
You didn't get test results yet. We planned an ECG and stress test for this 50-year-old woman with 2-week intermittent chest pain, tight, central, 4 out of 10, triggered by exertion, relieved by rest, shortness of breath, high cholesterol, 10-pack year smoking, and a father with a heart attack at 62. No hypertension, diabetes, or meds. Moderate stress, light alcohol use. Want to confirm the test plan? Ask another history question?
Yes, let's do the test and let's see the results.
All right, you proceed with the test for this 50-year-old woman with 2-week exertional chest pain, tight, central, 4 out of 10, relieved by rest, shortness of breath, high cholesterol, smoking history, and family history of heart attack. Results. ECG at rest is normal. No ischemic changes. Stress test, treadmill, shows ST segment depression and reproduces her chest pain and dyspnea at peak exercise, resolving with rest. What's your diagnosis guess now?
Well, ST segment depression, it means stable angina, right?
You're on point. ST segment depression on a stress test, especially with reproduced chest pain and dyspnea, strongly suggests stable angina in this 50-year-old woman with 2-week exertional chest pain, tight, central, 4 out of 10, relieved by rest, high cholesterol, smoking, and family heart disease history. It indicates myocardial ischemia from coronary artery narrowing during exertion. Want to confirm the diagnosis with the next step?
I want to ask, does STEMI and NSTEMI, is it only for stable angina or unstable too? Or are they different things entirely?
Great question to clarify. STEMI, ST elevation myocardial infarction, and non-STMI, non-ST elevation myocardial infarction, are types of acute coronary syndromes, ACS, specifically heart attacks, and are distinct from stable angina, though related to underlying coronary artery disease. Here's the breakdown. Stable angina, chest pain, like your patient's tight exertional pain, from temporary myocardial ischemia due to fixed coronary narrowing, relieved by rest nitroglycerin. Stress test may show ST segment depression, as in your case, but no infarction, no heart muscle damage. Unstable angina, chest pain at rest or with minimal exertion, unpredictable, signaling worsening ischemia without infarction. It's part of ACS, can show ST depression or T-wave changes, but no cardiac enzyme elevation, unlike STEMI, non-STEMI. STEMI, full coronary artery blockage causing heart muscle damage, with ST elevation on ECG and elevated cardiac enzymes, troponin, requires immediate reperfusion, e.g. angiography. Non-STEMI, partial blockage, heart damage, elevated troponins, but no ST elevation, often ST depression or T-wave changes, managed urgently but less emergently than STEMI. Your patient's exertional pain, ST depression on stress test, and symptom pattern point to stable angina, not STEMI, non-STEMI, no rest pain or enzyme.
Okay. So, yes, what is the next step? You said something about coronary angiogram?
Yep. For this 50-year-old woman with stable angina, 2-week exertional chest pain, tight central, 4 out of 10, relieved by rest, with shortness of breath, ST segment depression on stress test, high cholesterol, smoking, and family history, the next step is a coronary angiogram to visualize coronary arteries and confirm the extent of narrowing causing her ischemia. This guides treatment, e.g., stents, medication. Alternatively, you could start medical management, e.g., aspirin, statins, nitroglycerin, and monitor. But angiogram is...
Tell me, continue. Excuse me.
No worries. Want to dive back into the STEMI, non-STEMI versus stable angina discussion, confirm your patient's diagnosis, or push forward with next steps for her case, like a coronary angiogram or management? What's the plan?
Well, tell me about what I will do now, coronary angiogram. So what is this coronary angiogram?
A coronary angiogram is a procedure to visualize coronary arteries for your 50-year-old woman with stable angina, 2-week exertional chest pain, ST depression on stress test, high cholesterol, smoking. A catheter is inserted, usually via wrist or groin. Dye is injected, and x-rays show artery narrowing or blockages, confirming ischemia. Next steps. If significant stenosis is found, consider angioplasty, stenting, or meds, e.g. aspirin, statins, nitroglycerin. Want to explore angiogram risks, management options, or another history question for her case? What's up?
I don't know. Tell me the conclusion and we go to one more case. Okay?
Conclusion for your 50-year-old woman with 2-week exertional chest pain, tight central, 4 out of 10, relief by rest, shortness of breath, high cholesterol, smoking, and ST depression on stress test. Diagnosis is stable angina, likely from coronary artery disease. Proceed with a coronary angiogram to confirm artery narrowing. Then manage with meds, statins, antiplatelets, nitroglycerin, or possible stenting. New case, GI focus. A 35-year-old man presents with 3 months of epigastric pain, burning, 5 out of 10, worse after eating, with bloating and occasional vomiting, no weight loss or blood in stool. What's your initial guess, or what question do you ask first using Socrates?
Tell me again.
New GI case. A 35-year-old man has 3 months of epigastric pain, burning, 5 out of 10, worse after eating, with bloating and occasional vomiting, no weight loss or blood in stool. What's your first guess for his condition, or what question do you ask using Socrates?
GERD.
All right, let's roll with it. For this 35-year-old man with 3 months of epigastric pain, burning, 5 out of 10, worse after eating, plus bloating and occasional vomiting, no weight loss or blood in stool. What's your initial diagnosis guess?
GERD. How do we say reflux?
Nice. GERD, gastroesophageal reflux disease, is a strong guess for this 35-year-old man with 3 months of burning epigastric pain, 5 out of 10, worse after eating, with bloating and occasional vomiting, no weight loss or blood in stool. To dig deeper with Socrates, what's your next question, e.g., triggers, relief, associated symptoms, to confirm reflux or rule out other causes like ulcers? What's your move?
I'm not sure. How can I say that it's not enough? What should I ask to know it's not an ulcer?
Great thinking. Ruling out a peptic ulcer, e.g., gastric or duodenal, is key for this 35-year-old man with 3 months burning epigastric pain, 5 out of 10, worse after eating, bloating, and occasional vomiting. To differentiate GERD from an ulcer, ask, does the pain improve or worsen with food? GERD often worsens post-meal. Duodenal ulcers may improve with food. Gastric ulcers worsen.
Why they improve with food?
Duodenal ulcers, unlike gastric ulcers or GERD, often improve with food because eating stimulates bicarbonate secretion in the duodenum, neutralizing stomach acid temporarily, which soothes the ulcer's irritation. Pain may return 1 to 2 hours later as acid production ramps up. For your 35-year-old man with 3-month burning epigastric pain, 5 out of 10, worse after eating, bloating, and vomiting, this makes GERD or gastric ulcer more likely than duodenal. What's your next question to confirm GERD or rule out ulcers further?
Explain this to me more.
Alright, let's break down why duodenal ulcers improve with food compared to GERD or gastric ulcers for your 35-year-old man with 3-month burning epigastric pain, 5 out of 10, worse after eating, bloating, and vomiting. Duodenal ulcers in the small intestine are irritated by stomach acid passing through when the stomach is empty, causing pain. Eating triggers the release of bicarbonate in the duodenum, which neutralizes acid, temporarily reducing irritation and pain. Relief lasts 1 to 2 hours until acid builds again. Gastric ulcers in the stomach often worsen with food because eating stretches the stomach or increases acid, irritating the ulcer. GERD, like your patient's symptoms suggest, worsens after meals due to acid reflux into the esophagus, especially with lying down or trigger foods. To confirm GERD versus ulcers, ask, does the pain change with specific foods, e.g., spicy, fatty, worsen GERD? Any relief with antacids? What's your next question or guess?
I don't know, dude. I need some help from you, to be honest with this.
No stress, let's work it together. For this 35-year-old man with 3-month burning epigastric pain, 5 out of 10, worse after eating, bloating, and occasional vomiting. GERD is a good guess, but we need to rule out peptic ulcers, gastric, duodenal. Try asking, do antacids like Tums relieve the pain, and how quickly? GERD and ulcers often improve, but faster for GERD. Or, any specific food triggers like spicy or fatty foods? GERD worsens with these. Ulcers vary. Want to pick one of these questions or try a test, e.g. PPI trial? What's your next step?
Yes, let's do it.
Cool, let's move forward. You asked the 35-year-old man about antacids and food triggers for his 3-month burning epigastric pain, 5 out of 10, worse after eating, with bloating and vomiting. He says, antacids like Tums relieve the pain within 10-15 minutes, but it returns later. Spicy foods and coffee make the pain worse, no improvement with bland foods. What's your updated diagnosis guess? GERD still top? Or what's your next question or test, e.g. PPI trial, endoscopy?
I don't know. Sorry,
No
guys.
wor-
This is hard for me.
No worries at all, it's tricky stuff. Let's simplify for your 35-year-old man with 3-month burning epigastric pain, 5 out of 10, worse after eating, bloating, vomiting, relieved by antacids in 10-15 minutes, worsened by spicy foods, coffee. GERD is still likely since antacid relief and trigger foods, spicy, coffee, strongly point to acid reflux. To confirm, try this question. Does lying down after meals worsen the pain? GERD often flares when lying flat. Or, test with a 4 to 8 week trial of a proton pump inhibitor, PPI, like omeprazole, to see if symptoms resolve. Pick one, or want me to guide you to a test. What's your move?
Yeah, guide me to a test and we'll do a respiratory one and then, yeah.
Alright, let's wrap this GI case and set up a test, then pivot to a respiratory case. For the 35-year-old man with 3-month burning epigastric pain, 5 out of 10, worse after eating, bloating, vomiting, relieved by antacids, worsened by spicy foods, coffee. GERD is likely. Test. Start a 4 to 8 week trial of a proton pump inhibitor, PPI, e.g., omeprazole, 20-40 milligrams daily, to reduce acid and confirm GERD if symptoms improve.
How will
If no-
omeprazole help?
Omeprazole, a proton pump inhibitor, PPI, helps by blocking acid production in the stomach, reducing acid reflux into the esophagus, which likely causes this 35-year-old man's 3-month burning epigastric pain, 5 out of 10, bloating, vomiting, worsened by spicy foods, coffee, and relieved
Okay.
by antacids.
Let's do a resp one. A respiratory one.
Let's jump into a respiratory case. A 60-year-old man presents with a 4-month history of worsening shortness of breath, 6 out of 10. Worse with exertion, e.g., walking upstairs, and a chronic cough producing yellow sputum. No chest pain or hemoptysis, but he's fatigued. What's your initial guess for his condition, or what question do you ask first, using Socrates or history taking?
So he has chronic cough and sputum, yellow, and shortness of breath, 6 out of 10 you said? I don't remember. Exertion, makes it worse. No chest pain, no hemoptysis. Well, let's see the usual suspects. We have COPD, Chronic bronchitis, maybe.
You're thinking COPD or chronic bronchitis. Solid guesses for the 60-year-old man with a 4-month history of worsening shortness of breath, 6 out of 10. Worse with exertion. Chronic cough with yellow sputum and fatigue. No chest pain or hemoptysis. Using Socrates or history taking. What's your next question to refine your differential?
Well,
e.g.,
how long has this been going on for?
good call with Socrates. The shortness of breath and chronic cough with yellow sputum have been worsening over 4 months for the 60-year-old man. With shortness of breath, 6 out of 10, particularly bad during exertion like walking upstairs. And he's fatigued. No chest pain or hemoptysis. What's your next question? E.g., smoking history, triggers, or updated guess for his condition?
Yes, let's do smoking history. Let's do recreational drugs. Where does he work? And what's the house situation? Any mold in the house?
Smart move checking social and environmental history. You ask, he has a 30-pack year smoking history, 1 pack day for 30 years, still smokes, no recreational drugs. He works as a warehouse manager, no known chemical exposures. Lives in an old house, unsure about mold but mentions damp walls. His 4-month worsening shortness of breath, 6 out of 10, exertional, chronic cough with yellow sputum, and fatigue persist. No chest pain or hemoptysis. What's your next question or updated guess? COPD still top.
I don't know. I don't have any other questions. I guess I have to think about what tests we need to do now. What tests do we do for COPD, chronic bronchitis, and all of that?
No problem. Let's move to tests for the 60-year-old man with 4-month worsening shortness of breath, 6 out of 10, exertional, chronic cough with yellow sputum, fatigue, 30-pack year smoking history, and possible mold exposure, suspecting COPD or chronic bronchitis. Tests. 1. Spirometry to confirm COPD. Measuring FEV1 FVC ratio less than 0.7 indicates obstruction. Chronic bronchitis, a COPD subtype, shows similar results. 2. Chest X-ray to rule out other causes, e.g., pneumonia, lung cancer. If spirometry confirms COPD, consider bronchodilator response test. Want to confirm this plan? Ask one more history question, e.g., family history?
Yes,
or
yes, family history.
Good call on family history. You ask, and the 60-year-old man reports no family history of lung diseases like COPD, asthma, or lung cancer. Just a father with heart disease. His 4-month worsening shortness of breath, 6 out of 10, exertional, chronic cough with yellow sputum, fatigue, 30-pack year smoking, and possible mold exposure remain key. With COPD or chronic bronchitis in mind, your test plan is spirometry and chest X-ray.
Okay, and what the results show?
You run the tests for the 60-year-old man with 4-month worsening shortness of breath, 6 out of 10, exertional, chronic cough with yellow sputum, fatigue, and 30-pack year smoking history. Results. Spirometry shows FEV1 FVC ratio of 0.55, less than 0.7, confirming airflow obstruction consistent with COPD. Chest X-ray is clear, no pneumonia or masses. What's your diagnosis guess?
If it's restrictive or obstructive, restrictive means how's the differences in the graph? Let's see if we can Wikipedia it.
You're diving into the spirometry results for this 60-year-old man with COPD, confirmed by an FEV1 FVC ratio of 0.55, indicating obstruction. Let's clarify obstructive versus restrictive lung disease on a spirometry graph, keeping it simple for your case. Obstructive, e.g., COPD, chronic bronchitis, Airflow is blocked, so you exhale less air quickly. On the graph, FEV1, forced expiratory volume in 1 second, is low. FVC, forced vital capacity, total air exhaled, is normal or slightly low. FV1 FVC ratio, less than 0.7, like his 0.55, showing obstruction. The flow volume loop looks scooped out due to airway narrowing. Restrictive, e.g., pulmonary fibrosis, lungs can't expand fully, reducing total air volume. On the graph, FEV1 and FVC are both low, smaller lung capacity. FEV1 FVC ratio is normal or high, greater than 0.7. The flow volume loop is
Goski,
narrow.
okay. So, obstructive, we won't go as high as fast to the FEV1. Restrictive, we will never reach as high as normal. And this spirometry tests, it's when we blow air out. So restrictive will restrict exhalation because of trapped air, so it's not going to go as far away. Whereas obstructive, we don't restrict exhalation, but we just waste. Okay, sounds good.
You're getting the hang of it, but let's tweak your understanding of spirometry for clarity, tying it to your 60-year-old man with COPD. FEV1 FVC 0.55, obstructive. Spirometry measures how much and how fast you blow air out. Obstructive, COPD, like his case. Airways are narrowed, e.g., from smoking damage, so you can't blow air out quickly. FEV1, air in 1 second, is low. FVC, total air, is near normal. And FEV1 FVC, less than 0.7. Graph, flow volume loop is scooped. You don't hit high flow rates fast. Restrictive, e.g., fibrosis. Lungs are stiff, limiting total expansion, so both FEV1 and FVC are low, but FEV1 FVC is normal, greater than 0.7. Graph, smaller, narrow loop. You can't exhale as much air overall. Your patient's obstructive pattern, not restrictive, means no trapped air issue. It's slow exhalation due to airway blockage. Want to confirm COPD management? Ask another question.
It's all good. Let's call it a day. Thank you for watching, guys, and I'll see you all soon.